Hello everyone, can you hear me? Just type in the chat box if you can hear my voice or any voice coming at all from the presenter icon, the Iowa Healthcare Collaborative icon. Just so everyone knows, your voices are on mute. Okay, cool. We've got a couple of responses that say we are able to get sound, so great. So just so I'll start this over. I'm Jeff Woody, and I am representing the Iowa Healthcare Collaborative. Katie's not able to be here. Otherwise, Katie Reese, formerly Hodges, would be kind of overseeing this meeting and kind of addressing SDH. So without further ado, we're going to kind of dig into the presentation. Good afternoon, and welcome to the SDH webinar. This event is being offered as part of the Iowa State Innovation Model Programming in collaboration between the Iowa Healthcare Collaborative and the Iowa Primary Care Association. I'm Jeff Woody, the Communications Manager with IHC, and I'll be facilitating the webinar. A few housekeeping notes before we begin. All attendees will be on mute when they come in. If you would like to say something, make a note in the chat box or raise your hand on the attendee list, and we can potentially unmute you. We're going to try and keep all questions to the end of the presentation unless they've been asked and there's an interactive portion within the webinar. During our time together today, we will learn about the role that social determinants of health play in personal and community health and share meaningful actions that can be undertaken to help identify and address SDH at the point of care and across the continuum, including referral processes, partnerships, and using data to demonstrate success. This event will be an interactive webinar with opportunities to engage with speakers throughout discussion questions. We welcome and encourage you welcome each of you to participate through the chat function throughout the web event. Providing content and expertise, we are pleased to have Chris Esperson and Jim Addy. Please welcome me in joining Chris and Jim. So we're going to at least progress through. So if you at some point stop being able to see something or hear something, use the chat function or email any one of us that are present in the room, meaning Jim, Chris, or I believe Erica. Sorry, not Aaron. Erica, if you have any issues, feel free to contact any of us. We want to know that that issue is occurring and we can possibly address it before the end.
This is Ted Bozen, and I am the CEO of the Iowa Primary Care Association, and we are very excited to be on this journey with the Iowa Healthcare Collaborative and grateful for the SIN funding, which is being directed to this work. We are also grateful to the Iowa Legislature for their 10 years of funding and support of the Iowa Safety Net Collaborative Network, one of the very few kinds in the country. This last year, the collaborative has focused on identifying the need for more work in the social determinants health space, and we are very excited that we're about that work. Social determinants health is a great opportunity in Iowa. We are used to working together for change and can do so for the social determinants of health. We need to use the collaboration, hard work, and innovation Iowa is known for to address this challenge. We hope this project is the start of a more contemporary focus on improving care. Data can lead to improved, compassionate care and changes in payment and patient outcomes. We hope looking at social determinants of health and community programs more closely will be as valuable to the C3 communities and other stakeholders as it has been in the focus of the work of the Iowa PCA and the Safety Net Collaborative. We really do look forward to continuing this exciting partnership with the Iowa Healthcare Collaborative and the outcomes of this very exciting effort.
All right, thank you to Ted Bozen via a introduction on the internet for giving a presentation, giving a statement on the Iowa PCA's interest in joining this. For providing information, the people we're going to introduce now are Charles Bruner first. And Charles Bruner has been active for 40 years in child policy research, education, and advocacy, with a particular focus upon developing public policies that build resiliency and create pathways for vulnerable children and youth to succeed. He holds a PhD in political science from Stanford University, served 12 years in the Iowa General Assembly as a state representative and then senator, and was the founding director of the Child and Family Policy Center. He consults nationally with foundations, child advocacy organizations, and the child policy research community. Next, I'd like to introduce Chris Esperson. Chris is a quality consultant working with healthcare and public health organizations across the nation, providing technical assistance and new initiatives, data, patient engagement, and quality improvement. Prior to her consultant work, Esperson was the quality director at an FQHC in the Midwest. Chris has provided training and TA both domestically and to groups in Asia, Africa, and Latin America. She's an adjunct instructor at Drake, where she teaches social determinants of health. And next, I'd like to introduce Jim Addy. Jim Addy is the president of Mapping Strategies, a data analysis company specializing in evaluation services, analytical modeling for statistical comparisons, geospatial analysis for targeted marketing, including online outreach, and database constructions. Addy's prior research experience was with the Iowa Department of Education, where he oversaw school finance, education research, and information technology. Prior to IDE, Addy served as the principal investigator on a U.S. Department of Justice site evaluation and the SAMHSA site evaluation. He has an MPA from Drake University and a BSS from Cornell College.
Awesome. Thank you so much, Jeff. So a few things to be aware of to make the most out of this webinar. Resources are already available, and registrants will be receiving these resources in their inboxes soon. Like Jeff already said, there's going to be a few times we're asking you to interact during this presentation. So please be prepared to type your questions and comments and the reflections to the questions that we pose during this webinar. We will use these and reserve time at the end for additional Q&A. Finally, your time is valuable. Please make sure to make this session your own by giving us feedback throughout so we can make sure to respond to your important questions. And anything that you experience, if you can't hear, please let us know through the chat box so we can adjust our.
And one more quick housekeeping item. This is being recorded and will be posted on Simplify once we get it transcribed. So you will be able to rewatch or reread the content of this. And the slides will be presented within 48 hours with the SurveyMonkey of an assessment on the webinar itself. So you will be able to relive this information if you'd like to.
Wonderful. Thank you again. All right, so we're going to cover 4 main social determinant of health topics today. First, we'll cover utilization of social determinant of health information at the point of care and referral. We next naturally proceed to closing the referral loop, working with community partners, and last but certainly not least, data collection and analysis. So why now? Why are we focusing on this issue that public health is known to be significant for so long? Our broken healthcare system has the attention of providers, payers, and policymakers, and there's a political window open that is increasing general awareness and support for addressing the social determinants of health. So here's Charlie Bruner, who's going to give an overview of social determinants of health.
Well, I'm excited about this project in Iowa and addressing social determinants of health as part of healthcare systems transformation. Really, the health system has gone through transformations in the past from primarily dealing with disease and injuries and moving toward managing chronic health conditions and responding to those types of conditions, to really now focusing on how we can improve health and how we can have strong health promotion and health prevention strategies. And I think that's where social determinants come in, because we know that high-quality medical care plays a role in improving people's health and longevity, but the vast share of the factors that affect health and longevity are not medical care and treatment, but they're what are called social determinants of health. And that includes access to basic human services and needs, housing, transportation, food, clothing, but they also relate to the stresses that exist in one's life and the workplace settings that one's in, and how many social ties and connections one has, which also lead to lifestyle issues around involvement with drugs and addiction. So all of these relate to a person's health and longevity, these social determinants. And there is now, I think, really an emphasis on the healthcare system not responding in total to these, but being a good first responder and connecting individuals and families and kids up to the types of supports that they need.
just one quick reminder, if that is a little bit hard to hear, there was a couple technical issues in getting the videos to actually stream sound through. So once you get this presentation in the PowerPoint, you will be able to watch these videos back. Again, if you were hard of hearing in these and the volume when you turn it up, it loses quality or something like that. You will be able to watch these videos once you get the slides if you were wondering what exactly was said, if there is a little bit poor audio quality.
Okay, so I know you definitely can hear me. So now let's start a discussion by talking about utilizing social determinant of health information at the point of care so that we can make appropriate referrals. Social determinants can be addressed in a variety of settings. For now, we're going to talk about the medical setting. And towards the end of this section, we'll give other examples where social determinants of health can be identified and addressed. For a long time, providers have had various questions added to the medical visits: domestic violence questions, education levels, in some states, even presence of guns in the home was asked. That last one didn't go over so well in some areas. But these efforts many times didn't result in comprehensive nor effective screening and referrals for the various social determinants of health that impact an individual's health. Recent initiatives have recognized this issue and have sought to approach social determinants of health in a more holistic way that hopefully will have a positive impact on the patient. One such initiative is the PREPARE initiative that the National Association of Community Health Centers is leading at health centers across the country. PREPARE stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. So before you begin a local initiative, you must consider a few things. First of all, what is your goal? Next, how will you know you're approaching your goal? Hopefully you've identified some measures of success to let you know that you're headed in the right direction. Then you can know whether your next step, which is to test your theories, are leading you to your goal. If this looks familiar, it's probably because you have seen it. It's the Institute for Healthcare Improvement's Model for Improvement, and it represents the steps that we often forget when we plunge into something that is exciting, something like addressing social determinants of health. There are too many social determinants of health to cover in a webinar or even a series of webinars, so you probably can't deal with them all in your work setting either. It will be important to prioritize what you target for both your staff and your consumer's sake. There are a number of ways you can start small. You can start with categories such as a certain neighborhood, population, or topic. But a good way to make progress is by asking what is a big problem, or what is a problem we are pretty sure that we can do something about rather quickly. Thinking about significant problems in your community, you could look at issues that have a high historical or even recent prevalence. Or you could look at problems that affect a smaller group of people but have severe effects. A correlation to this in medicine are those patient safety issues that we term high volume and high risk. For those issues that we want to fix quickly, it will be important to ensure that there are resources available and accessible to your population of interest, and other feasibility considerations, such as existing efforts where resources can be leveraged for maximum impact. For more information on prioritization, along with other programmatic data considerations, see the Collecting Data at the Program or Practice Level issue brief that will be sent out after this webinar. Once you have identified which social determinants of health you will target, you'll need to ask the right questions in the right ways. There are screening tools available, such as PREPARE, or you can develop your own. But you will need to ensure that the questions are phrased in ways that will elicit accurate answers. The last thing you want to do is waste your staff's time or alienate the very people that you're trying to help. Here's a video to show the difference between effective and ineffective screening.
Good morning, Ms. Kuhine. I'm Dr. Sable. I'm going to be asking you a few questions. And this is part of our PREPARE survey, which is the protocol for responding to and assessing patient assets, risks, and experiences. Is that okay with you?
How long? I gotta pick up my kids, that's why.
I understand, and we'll try to get through this very quickly. Just a few questions. So first of all, Ms. Quihine, what is the highest level of school that you've completed? Have you gone to, have you finished 8th grade, or high school, or do you have a high school diploma, or have you gone to more than high school, college?
What is that? When I went to Waianae, but what is that called? The stuff that you get the GED stuff.
You have a GED?
Yeah.
Oh, very good. Okay. Now, Ms. Quihine, how many family members, including yourself, do you currently live with?
It depends. Can we not, so like me and my kids, or what you mean, like everybody? Like even,
how many family members live with you?
Well, like my family members are like, because my boyfriend, I mean his like brother is them, but then is that, like what you mean, like me and my kids? Like what is it for? Like does it matter? Because
well, we're just trying to gather some information to provide you services if you need services.
Well, got me and my kids.
How many children?
Me and my 2 kids. And then sometimes my boyfriend's daughter stays with us too. But then it's mostly me and my 2 kids.
Okay, let's just say 6. Okay. And Quihine, what is your housing situation today? Do you have housing and you're not afraid of losing it? Do you have housing and you are afraid of losing it? Do you not have housing? Are you staying with others in a hotel, in a shelter? Or do you not have housing, living like on the beach, in the streets, in a car, in the park? Or do you choose not to answer this question?
Okay, well, I just said that we live with my boyfriend's mom, them, in their house.
Do you live in a house?
In their house.
In their house. And are you worried about losing this housing, or?
No, that's it. That's it.
Okay, good. Okay, so you have housing and you're not worried about losing it. Okay. And so,
how many more? Because I gotta my kids out.
I know. Just a few more questions. Hold on one second. I just can't break her. I just can't break her. You try. Chrissy?
Yeah.
Hey, how are you?
Hey.
How are you today?
Good.
What did you come in here for?
To check my throat.
You start to go, Anna? You look familiar.
Yeah, I think my sister went to school, your sister.
Yeah.
And Waianae.
Waianae.
Yeah, you remember.
I remember.
Yeah.
How's she doing?
She's good.
Yeah. How much did she get?
Go to get planning.
All right.
More than me.
Yeah. Well, how much you have?
3.
3 kids. How old are they?
Yeah. She's back to back, so they're like 10, 8, and 7.
Oh, girl.
I don't talk about busy. Oh, girl, talk about stress.
Yeah. So they all in school right now?
Yeah, that's why I was telling that time that day. I gotta go pick them up.
Oh, yeah. Yeah. Well, Kristen's the doctor will be in next week, but just talk start a little bit. So you have 3 kids. I mean, so where are you living right now?
Sorry.
Hold on one second. I just can't break her. I just can't break her. You try.
Yeah. And Waianae. Yeah, you remember.
I remember.
Yeah.
How's she doing?
She's good.
Yeah. How much did she get?
Go to get planning.
All right.
More than me.
Yeah. Well, how much you have?
3.
3 kids. How old are they?
Yeah. She's back to back, so they're like 10, 8, and 7.
Oh, girl.
I don't talk about busy. Oh, girl, talk about stress.
Yeah. So they all in school right now?
Yeah, that's why I was telling that time that day. I gotta go pick them up.
Oh, yeah. Well, Kristen's the doctor will be in next week, but just talk start a little bit. So you have 3 kids. I mean, so where are you living right now? You're living at
we live at Highway Joe.
Yeah.
Okay, that's my home, and so we live with his mom then.
Oh, down in Mighty.
Yeah, same place.
Yeah,
it's kind of a big house.
Big house.
Kind of all, yeah.
You and there's 3 kids at Joe.
Yeah.
Right on. So you working?
No. I just don't watch the kids.
Right.
Yeah.
Good for you.
Yeah.
You can see them grow up. Yeah.
Yeah.
What about Joe? You working?
Yeah, off and on.
Good for you. What about like food stamps and things like that? You get that?
Oh yeah, I got that.
Good.
Good. That's some time.
Yeah.
Something I
need help, right?
Yeah, that I can get myself.
Food and stuff. Good
Yeah.
for you. How did you come up here? You have transportation?
No, well, I ended up calling to have the kind of
the van.
Yeah, the van.
Good.
Because I got her be home and then meet my kids.
Yeah, so the van then take you home after this.
Yeah.
Okay.
Yeah. So, I can be seeing them pretty soon.
Yes.
Okay,
After
cool.
we'll be in, but today's the guys.
Yeah. Okay, great on.
So thanks to our sister Community Health Center Waianae in Hawaii and to the Hawaii Primary Care Association for sharing that video. You can see when you have the relationship, you can get answers a little bit better from your clients, and then after that, you would refer them to the services. So now it's time to think about your internal processes and who is the right person to ask your patients or clients these questions. There are a lot of things to consider. There are role considerations such as current staff workload, scope issues, and which role are patients more likely to answer accurately to, like you just saw in the video. So there's also considerations that will depend on the individual, such as comfort in asking the questions and personal belief systems that could potentially interfere with appropriate handling of social determinants of health issues. Make sure to have a handle on these things and involve a small group of people that occupy the different roles in your setting in determining who will ask the questions, when they will ask them, and how frequently. Also think if there is something you can take off their plate when you're adding to it, or at the very least look at other things such as employee job descriptions and evaluations and adjust expectations to make sure they're still reasonable when adding these extra responsibilities. So your staff have appropriately screened the patient and the patient has identified their social determinants of health. The next step is very important, as you don't want to drop the ball and have the individual fall through the cracks. The first step may seem silly to some, but in some organizations, the person who does the screening may not be the same person who makes the referral. So it's really important to have effective documentation and communication systems, that there are training and manuals behind these systems, and that there's an auditing process to make sure that the appropriate follow-up is occurring. The next thing to do, obviously, is to refer to the appropriate agency. We'll talk more about referrals in the next section. So you'll also want to have set up tracking systems. First, you want to track the referral so that you can close the loop, which we'll discuss in the next section. You also want to track screening outcomes. For example, how many people need transportation or supplemental food? You may want to track this over time and even stratify the different populations, as it will be helpful to your community to know how much of a particular resource is needed. If you're able to, it's also useful to track outcomes or determine if your partner agency is able to track outcomes. This could be percent of clients permanently housed or those who are able to increase their income as a result of workforce development programs. You will want to use these data as well as other quality improvement data to make your processes as efficient and effective as possible. So here you can see some different types of social determinants of health interventions at the point of care. We won't go through all of them. You can do that on your own, but you can see, for example, food insecurity is something often screened for at schools. And so people are connected to the school lunch programs, the summer feeding programs, and partners and farmers market benefits as well in some schools. In the clinic, we screen for limited English proficiency, or we know this based on what our patients prefer to speak. So we could not only interpret for them at the point of care, but we could connect them to refugee service providers with translation and English classes so they can learn it on their own. So all of these interventions on this slide I have witnessed or I've read about in the literature. When you think about it, any place we go, there's an opportunity to connect a fellow human being to something that can improve their life, and it might even improve something for your business or organization. Just imagine the possibilities when a community truly embraces the concept of no wrong door for their neighbors and fellow community members. So let's take a brief moment for you to reflect on this section. Now is the time to be locating your chat box and use it to answer one of these two questions. So one, what are some examples of integrating social determinants of health interventions at the point of care? Or what additional questions do you have regarding integrating social determinants of health interventions at the point of care? We will be prepared to answer your questions towards the end of this webinar, and we would love you to share your creative examples. So right now we don't see a lot of people typing in, but we will continue to ask you to do this throughout the webinar, so be prepared for next time. All right. If you think of anything creative, please go ahead and share it, and we'll touch base on it later. So now we'll talk about the closed loop referral process. So more and more attention is being paid to outcomes versus process measures in healthcare. When before our hands were clean once we made the referral, now the onus is on us to ensure that we document and communicate all relevant information, monitor status of the referral, identify and remove barriers to ensure the referral is completed, and in many cases, integrate the results of the referral back into our own system. This is the essence of a closed-loop referral. So you can see here a very simple, high-level view of a client flow to your agency. Ideally, all of these tasks would occur. However, with each step, there's an opportunity for the workflow to be broken. Perhaps the issue was not documented in your system, making it hard to follow up. Maybe not enough information was included in the referral, which causes your internal staff to have to go back and forth to ensure the right information is sent to the other service provider. Or maybe the other agency can't do what they need because they don't have the information they need. All these breaks lead to a delay in service provision or may prevent it from occurring at all. So these are the reasons why having a way to track your referrals is so important. It doesn't matter whether it's a wonderful integrated system that automatically can do all of this, or even an Excel sheet or paper tickler file. The critical point is that you have something in place to prevent people from falling through the cracks. Staff training and competency checks are helpful to ensuring effective processes stick. Finally, using motivational interviewing and patient engagement techniques are also important to this process. Unfortunately, we do not have time to cover all these topics today. So let's talk about the benefits of a closed-loop referral. One is that they might help you meet your requirements. For example, primary care practices that have patient-centered medical home certification are required to show completely documented and closed referrals. Federally qualified health centers also have referral tracking as one of their 19 requirements when they have an MOU or MOA with another agency. For medical referrals, there could be malpractice or liability insurance requirements as well. While social determinants of health referrals can be different than critical tests and procedures, there are other benefits of closing the loop. For your own organization, ask yourself how certain information makes your system more efficient for services in high demand. What does information provide you to help your organization effectively address other areas of high need? And finally, how can you leverage the outcomes and benefits provided by this intervention for future funding? And finally, having information from a completed referral might benefit your clients. How can more information help prevent adverse outcomes and improve their overall quality of life? So sometimes you might want the information, but you can't get it back from the agency. Here are some tips to get that referral information back. I don't know about you, but I've been in a room with people who are in the midst of change and in too much information. I've heard groups make decisions in those meetings that they will go and tell another agency to stop sending those faxes to appease their upset, information-overloaded staff. This and other scenarios may have occurred in the past, so it might just be a conversation about why and how things have changed, and why all of a sudden you do want that information. Sometimes we get overwhelmed or frustrated by the amount of change occurring in our environment, and we need a reminder of why we do what we do. Sharing a story about a mutual client may help your partner understand the importance of getting information back. We've had situations where we have a close relationship with a patient, and they might be very pleased about the service they received elsewhere, and so we find out about the connection in that way. Conversely, someone may be lost about next steps regarding a referral, and if we come with good expectations, we can work with our partner to share that information and help the patient. Do you ever have to send a reminder to do something, like take your medications or change your furnace filter? Those prompts are part of our system to get tasks done to keep us or our furnace functioning properly. Our referral tracking system can help us remind our partners to get information back to us. Or maybe they even start doing it themselves so they don't have to get our reminders. In our experience, we've also had partners who experience scope nudge. They try to get us to do things that they really should be doing themselves. And they try to convince us that we won't have to harass them to get the information back if we just do it ourselves. Our strategy has been to kindly but firmly set boundaries and remind them of their role versus our role, and to be aware of what statute, funding stream requirements, or other structures ensure are separate but equally important roles. Finally, building, maintaining, and nurturing relationships is always the best tactic to get what you want. We'll cover some of these considerations on that in our next section. So it might also help to know that these same tips also could help convince community partners to refer to your organization as well. Okay, so now it's time for you to let us know what you're doing. Think about these 3 areas and type in the chat box an example of one of these that might be pertinent for your organization or great strategies you've used to get information back. Alternatively, feel free to ask a question about closed group referrals that you would like us to address at the end. So if you have any ideas, now is the time to share as we're all learning from each other today. All right, so now we'll move on to the importance of developing and nurturing community partnerships to effectively address social determinants of health, because this is work that we cannot and should not do alone.
What I think is really emerging in the health world is both working with individuals and families which may have chronic health conditions or concerns and providing something that goes beyond medical care and is a care coordination. So if that senior who has diabetes and has difficulty maintaining their regimen has some other care coordinator or supporter who helps them maintain their lifestyles, that can do a lot to reducing long-term health care costs, but maintaining a person's health. If a child has a major physical disability, that child needs medical care and treatment. But if there's also someone who can help that child and family navigate what is in the community and also help the child to be just a regular kid interacting with others, even though they may have a disability, that goes a long way to promoting health. So there's that work on the side of people who have conditions that otherwise could be major health costs and tend to be chronic to maintain themselves better through some form of care coordination in the health system going beyond medical care. There's also health promotion and more preventive approaches. And particularly when it comes to kids, and particularly when it comes to young kids, you really can't talk about the health of a 2-year-old outside the context of are they living in a safe, stable, and supportive family. And if they are living in that safe, stable, and supportive family, they're going to do pretty well, and their health needs are going to be managed. If they're not, they're going to be subject to adverse childhood experiences and potentially types of stress and toxic stress that have huge ramifications on their future health. So really, the focus with social determinants is to still say the medical practitioner has received all this training so that they know how to deal with those medical conditions, and they are needed for that expertise. But that's only really going to be effective in as much as the individual patient or family also has those other social ties and connections and ability to manage their world. And I think that the major hope, I think, with our health system in terms of managing costs is through improving the health of people so that they're less likely to have the chronic diseases that do end up taking up so many of our healthcare dollars.
All right, so the CDC has developed a comprehensive guide on advancing health equity. A chapter of this guide includes steps to build effective partnerships. We'll summarize these steps here, and you can access the entire guide online. The first step is understanding the history of the community and engagement efforts. This way you can learn about successes, failures, and any issues that could waylay your efforts. The next concept involves building relationships early, ideally before you request anything and before issues become serious. Trust is essential to moving forward together. You should also assess and address organizational barriers to community engagement. These barriers can include time, skills needed, and doubts about the effort itself. To mitigate these issues, develop systematic plans and partner with well-established organizations to help support the effort and build staff capacity. Consider your audience when selecting techniques, and make sure to tailor them to specific purpose and other parameters. Also consider the resources that are available. These techniques range from forums to research or focus groups and assessment and mapping. Some populations who experience health disparities have stigma, limited English proficiency, and other barriers that prevent participation. Childcare, transportation, and the varied determinants of health that we're trying to address may be barriers to experiencing participation and providing input. Engagement activities should build the capacity of our community members. Ideal activities increase awareness of health inequities and provide skills on how to intervene. Leadership development and coalition building not only benefit community members, but can aid sustainability of your efforts. Finally, it's important to balance and respect community expertise with technical expertise. So we'll now cover additional tips that we found helpful in effective partnerships. First, it's important to assume the best in each other, especially when checkered paths exist between agencies. Sharing success and storytelling can strengthen your relationship. Create an agenda and assess use of meeting time so that you respect each other's time and are productive in meetings. Finally, leave with specific and mutually understood action items, with deadlines and owners to ensure positive forward momentum. So you can see in this slide that there's no shortage of potential partnerships. For time, we're not going to go through all these individual partnerships, but again, you can access this to look at ways that you can creatively partner in your community. So again, because of time's sake, there's some questions to be thinking about as we go on. Feel free to type in places that you are currently partnering with that you find to be really innovative or creative, or you could also say which people that you're not partnering with but would like to. So now we get to the exciting part, social determinants of health data. I'll pass it over to Jim to discuss this crucial topic.
Hello, this is Jim Addy. Next, we're going to talk about finding data on social determinants of health. It's my role to provide TA with the data in this project. So let's begin by framing the discussion. What are social determinants of health? Operationally, we're talking about macro or population-wide social characteristics that affect health. All right. There are 5 domains of the social determinants of health from the Healthy People 2020. So we have those listed here: economic stability, education, social and community context, health and healthcare, neighborhood, and built environment. And then we've taken the time to give you examples of each of those domains, such as with economic stability, there's poverty, employment, food security, housing, stability. Education has graduation rates, enrollment rates, literacy, and early childhood factors. Social and community context, social cohesion, civic participation, discrimination, incarceration, health and healthcare access, access to healthcare, access to primary care, and health literacy. And then our 5th one, neighborhood and built environment, has access to healthy foods, quality of housing, crime and violence, and environmental conditions. Before we look at the data itself, we need to make a few decisions. What is your purpose or objective, and what types of data will help you create a strategy to achieve your objective or purpose? Bullet 1 is something that Chris addressed extensively, especially when she was describing programs that are fairly mature, that have program evaluations and necessarily have that feedback loop. Bullet 2 is what we're going to talk about more, and these are research designs to assist younger programs. They're often what are referred to as either targeting or benchmarking. In targeting, you're looking for groups who you should go after, or in benchmarking, you're more concerned with where do we stand now so we can plot a course forward. So here are 3 different strategies that you can use. Theories are often very helpful. As you heard Dr. Bruner talk about some of his research into adverse childhood experiences, or ACE, he's written some articles on that, and we'll discuss that later, where he uses census categories plus local data to look at variables affecting children. There are also some best practices that target certain populations, certain subgroups, to achieve certain ends. And we're all aware of, and we're all reaching out to Chris for TA on certain best practices. And if you're not sure what you're going to do, as a data analyst, there's always data mining. So SDOHs that are prevalent in your area, which we can identify from the data that occur at high rates in localized areas, or that are spread throughout a region. SDOHs that are related to your specialty provided by your organization, so we can search those out in your data or in the aggregate data that's provided by agencies. And SDOHs that are more prevalent in your most concentrated customer areas. And that's a two-step process where we look where your customers are by mapping them, summing them up, and looking at some of those data. So you've heard about 3 strategies for younger programs. So now I'm going to move on and actually use Dr. Bruner's research as an example from one of those. But first, where do we get the data? We're going to get the data the same place Dr. Bruner did. There are many places you can get data, so I do not want to neglect any of them. Healthy People 2020, a great place. Iowa Department of Public Health, great county level data. Iowa Department of Education, used to be administrator there, great data at the school district level and sometimes the elementary school level. There are value in other data sets for some of these domains, but what's nice about the U.S. Census is that they have something in each domain. And you can see the link there to American Fact Finder. And in fact, if you look on the right side of the slide, you can see all the types of data that are available through American Fact Finder. And just for those of us that aren't census or aren't data folks, the census is no longer one agency. We have in American Fact Finder many products from many different agencies. And also one thing that you're going to have here is the fact that these are very recent data. They're 2015 data, where many data sets lag. All right. So, there are many types of analysis that can be performed on these data. For this project, I'm especially stressing analysis with geographic information systems. This is a type of analysis that's used in public health and can be particularly robust. Basically, we're going to display data on a map. What we're going to do is we're going to look at per zip code is how the data are displayed. That'll be our unit of analysis, which is fairly granular here in Iowa. We're talking about 937 zip codes, and it works especially well for rural areas that don't have as many census tracts as urban areas. We're also going to use the GIS boundaries from the census so that we know that we have reliable boundaries. We perform all these spatial representations or analysis, and we're able to provide you a number of different outputs. So this is more tailored towards the SIM grantees. When we do these sort of analyses, we can provide you with hard copies or static maps, so graphics that can be used in your newsletters, websites, or for presentations all the way up to wall maps. We also can provide you access to an online tool where we put the data on the tool that you requested so you can use it and you can have it for later to work with. And we'll also entertain any other customization. In that regard, while we are stressing GIS, we do all sorts of columnar analysis, descriptive statistics, program evaluations with ANOVAs and comparisons. All right, but let's look at some examples of these in the next few slides, some of these GIS. So next slide. Thank you. This is the simplest representation of data on a map. Well, you believe it or not, you have all your 937 zip codes. You have the 6 different grantee groups, and we can see their relationship together. So really simple data, but a good place to start. Visualization can help us. All right, second map we're going to turn to now is of childhood poverty. And we're going to use Dr. Bruner's research for a quick example. Dr. Bruner's research compared census tracts. We're using zip codes, so I just want to point that out again. One of the variables it considered was poverty rate. And this slide shows the poverty rate for the Webster County Health Department C3. And you can see in the scale we go from 0 below the federal poverty line for children all the way up to over 40% of the children in that zip code being below the federal poverty line with the red hashes. Right? This is the variable he uses for comparing the other 11 variables in his research, as we'll see in the next slide. All right, the next slide is poverty in single-parent families by zip code. What we've done in this slide is we just added one more layer, the light red to dark red, and it is the single-parent percentage of single-parent families. So now you have actually 4 different layers going on all at once, and we've labeled the percentage of single-parent families. So on this map, one can see a correlation between zip codes with a high percentage of child poverty and a high percentage of single-parent families. The correlation can be easily visualized by comparing the 2 ends of each scale for each variable. Where the poverty is low, the percentage of single-parent families is low. Where the under 18-year-old poverty rate is low, those equally spaced dots, the percentage of single families is also low, the light red scale. Specifically, of the 20 zip codes in the Webster C3 and the 2 lowest poverty categories, most, or 18 out of 20, have low percentages of single families. Only 2 were in the high percentages of single families. On the other end of the scale, where the poverty is high, the percentage of single-parent families is high. Where there are zip codes with high percentages of single-parent families, the dark red, most of the time, there is a high childhood poverty rate, either the red hash X's or the black hash X's. So this is sort of a truncated analysis for demonstration purposes of how you can look at correlations with mapping. That's one thing that we do, and that's what we use Dr. Bruner's research. The next slide also gives you an idea of a second type of spatial TA that's available. Right here is a live link to ArcGIS Online. We pulled up the social determinants of health of disabilities, persons with disabilities, and unemployment rate. And we have those mapped out for all of the C3 grantee, all 6 areas. And it is a really powerful tool that you can do a number of things with. If you want to play with it, please feel free to click on the link, and it's the platform that we can use to add all your data to so you can have an online tool. The last thing I just briefly wanted to mention is the customization. The last page is mapping community resources for baseline or referral. As GIS, we can take any list of addresses and we can map it. When you're actually looking at the zip codes themselves, what happens for the census is they just sum up all the people in those zip codes and they create their statistics. We can do the same thing with your list if you give us a list of addresses. So that helps us, for you, if you want to follow through the research, look for community resources, look at the difference in community resources between your areas, or just have an online referral map of community resources. So that gives you a little specific explanation of what we can do for you with your data and how you might be able to use it in geographic information systems if you're a little younger program trying to figure out where to go. And now I will turn it back over to Chris.
All right, thanks so much, Jim. Those maps are beautiful. So we've covered a lot of ground. Now it's time to piece it all together.
Iowa's made a commitment to being the healthiest state in the nation, and I think we have a lot of strengths upon which to build. We have a lot of exemplary practices in the field that really are responding more preventively and more comprehensively to individuals, and we're showing real gains there. I think our challenge is going to be in moving these exemplary practices to being the standard of practice and to building in the types of services that they provide or refer to that are non-medical into our thinking around what is a health system. And if we can do that, I am really confident we can be the healthiest state in the nation. And also, that leads to greater productivity, greater overall prosperity, and really helps to control the the types of costs that we're otherwise going to experience because of debilitating health conditions.
All right, so hopefully the points covered in this presentation are helpful to your future or even current social determinants of health initiatives. Every step of the process, from screening to building partnerships, to closing referral loops and collecting data, are essential to your journey of improved service provision and our mutual improved community health. It's important to remember that while we seek to break down the barriers for the people we serve, we also need to break down our own barriers that prohibit us from working together in effective ways. So if you have any questions, please feel free to type them as we wrap up in the next slides. And there are a number of things that you can look forward to in the coming months. There will be a second webinar in early January focusing on sustainability. Some people are aware that we've been talking with the C3s individually about how the Iowa PCA might assist them with their social determinants of health efforts. We're developing resource documents and a video podcast series highlighting organizations around the state addressing social determinants of health in different ways. Stay tuned for more information on these resources.
All right, thank you to Chris and Jim for an excellent presentation. As a reminder, the event is being recorded or was recorded and will be archived on the Simplify website once we get the website transcription back. We encourage you to share this recording with your coalition members and your community stakeholders, or anyone who basically could see use out of them. The post-event survey will be sent to attendees within the next 24 to 48 hours. We appreciate all your feedback as we continue to develop educational offerings and always look to improve. Once again, if there are any questions, don't hesitate to shoot emails to anybody that's been on this list or that is anybody in the responses that you will get in the post-evaluation survey. Please feel free to interact with both IHC, IDPH, and Iowa PCA. Thank you for your time.